approach to young diabetes. So based on what we have seen as 4 examples, let's just look at a patient with a diabetes onset less than 30 years. Okay. And after infancy. Why did I say after infancy? Because before infancy, that is in the first year of life, you can have another cause called as neonatal diabetes. There can be an entire spectrum of causes resulting in neonatal diabetes. So I'm not referring to that. Okay. So first things first, you have to rule out a life-threatening cause or a condition if left untreated can lead to dreadful complications like diabetic ketoacidosis. So the first thing that you will have to look at in a new onset young diabetes is that whether it is a sudden onset patient with severe osmotic symptoms or features of acidosis. Because if it is there, it has to be type 1 diabetes most likely. So if features of ketosis or ketoacidosis are there, you send for islet autoantibodies and you make the diagnosis of type 1. If it is positive, you make it as type 1A and type 1B if the autoantibodies are negative. So those arm is straightforward. So rapid onset, osmotic symptoms, decay, you send for autoantibodies. If it is positive, type 1A diabetes, negative, type 1B diabetes. The newer WHO classification doesn't explicitly say about type 1A and type 1B, and so does the ADA. So this is one of the older flow charts. But currently, even in patients who are negative, you call it as autoantibody negative type 1 diabetes rather than a type 1B diabetes. Okay. So you are going to the other extreme. If the patient is not having osmotic symptoms or decay, you look for the features of insulin resistance and obesity, because the 2 major causes are of always type 1 and type 2. So always look for the features of type 1 and type 2 first. We're looking for the features of type 1 in the form of decay. Now we are looking at the features of type 2, strong family history, obesity, features of insulin resistance, etc. And if all these are positive, you look for the family history also. Then you make a diagnosis of type 2 diabetes, always accompanied by the C-peptide measurement and all. Okay. Now, if the patient is non-obese, no features of IR, then you take a specific note of the family history, whether it is a 3-generational family history or a mitochondrial inheritance, and you make the diagnosis accordingly. If there is no family history, then you see if there are features of lipodystrophy and severe insulin resistance. Then you make a diagnosis of lipodystrophic DM, and if you get the history of malabsorption, abdominal pain, or in the X-ray you get an evidence of the pancreatic calculi, you make a diagnosis of fibrocalculous pancreatic diabetes. So it is always important to have a list of differential diagnoses in young diabetes, starting from type 1, then type 2, then monogenic causes like MODY, mitochondrial and lipodystrophic diabetes, and not to forget the very important fibrocalculous pancreatic diabetes.